Ladies and gentlemen, good afternoon. My name is Giuseppe Curigliano. I work at the European Institute of Oncology, Milano and University of Milano. I thank a lot the organizing committee for inviting me to discuss about immunotherapy beyond triple negative breast cancer that I believe is really a major need finally, and we need also to understand if is there an opportunity also in this patient population. Those are my disclosures. So this is the outline of my presentation. I will try to discuss first about the rationale to target breast cancer beyond the triple negative breast cancer. Then we will discuss about evidence from clinical trials of immunotherapy in HER2 positive breast cancer. Then we will try to address the evidence from clinical trials of immunotherapy in HR positive breast cancer. And finally, we will try to define an immunogram in order to predict response to immunocheckpoint inhibitors beyond triple negative breast cancer. And we will give our conclusions. So, which is the characteristic of biomarkers for immunotherapy? There is a clear difference between traditional genetic driver alterations and immuno-oncology biomarkers. First of all, the location of immunomarkers, that is both in tumor and microenvironment. And when we discuss about the driver of response to a targeted therapy, usually the biomarker is in tumor cell. Then about presence and prevalence, that is stable in case of a traditional genetic alteration, and is dynamic and inducible when we discuss about immunobiomarkers. Regarding the host influence, this can be very weak eventually in genetic biomarkers, but it's really important when we discuss the host for immunobiomarkers. And also in terms of measurement, we have a binary expression for genetic biomarkers, and we have an expression range of magnitude for immunobiomarkers. Just think about tumor infiltrating lymphocytes, PD-L1 expression, eventually tumor mutational burden. So, can we target with immuno-oncology HR positive and HER2 positive disease? If we start from the current biomarkers, we can consider the mutational burden, so the tumor mutational load. Incidentally, sometimes we may have some HR positive or HER2 positive disease with high tumor mutational load. T-cell infiltration, and here it's clear that in HER2 positive disease and in some HR positive disease, T-cell infiltration can be a predictive and prognostic biomarker. And finally, PD-L1 expression, that is both present in HR positive and HER2 positive disease. So the primary question is how to turn a cold tumor into a hot tumor. This was the hypothesis also of all the clinical trials that have been conducted in the context of the triple negative disease. We used chemotherapy in order to induce a higher immunogenic cell death, and then to release tumor antigens, upregulate PD-L1 expression, upregulate immunogenic cell surface markers, and finally, activating the immune system in order to be more responsive to the activity of immunocheckpoint inhibitors. So you can boost with the immunocheckpoint inhibitors a tumor and a microenvironment that has been activated by chemotherapy potentially. So let's start discussing about evidence from clinical trials of immunocheckpoint inhibitors in HER2-positive breast cancer. So if we look at all the clinical trials ongoing in breast cancer, we have many of them concentrated in HER2-positive disease, 24 in the metastatic setting, 13 in the adjuvant setting, 8 in the neoadjuvant setting. Very few for ER-positive disease. We have many of them in the metastatic setting, 1 only in the adjuvant setting, and 6 in the neoadjuvant setting. Let's start with HER2-positive disease. The first seminal hypothesis-generating trial in the context of HER2-positive disease was the Panacea trial. There was a rationale here. HER2-positive breast cancer usually may have high tumor-infiltrating lymphocytes, and TILs are usually associated with an improved prognosis and response to trastuzumab and chemotherapy. And trastuzumab also has been shown to have an immunomediated mechanism of action. So there was a rationale to combine entire 2 agents plus immunocheckpoint inhibitors. Also looking from data in the context of the clinical trials like the FINAIR, Sheryl Lloyd demonstrated that the lymphocyte predominant breast cancer usually have a better prognosis. That's why the Panacea trial was designed. The trial has inclusion criteria, included patients with centrally confirmed HER2-positive breast cancer, with a tumor biopsy of less than 1 year, no limit of prior systemic treatment, and documented progression on trastuzumab and T-DM1. It was a phase 1, phase 2 study, and eligible patients were PD-L1 positive disease, even if there was a cohort also very limited for PD-L1 negative. And the primary endpoint was finally response rate. 146 patients have been screened. 68 of them were positive for PD-L1, a little bit more respect to the PD-L1 positivity in the context of triple-negative breast cancer. Here we have 53% of patients screened that were positive for PD-L1. The enrolled patients in the context of the trial were 58, of whom 6 had been enrolled in the phase 1b and 40 in the phase 2 study. 41% were ER positive, 59% ER negative, and 12 PD-L1 negative, half ER positive, half ER negative. So at the final analysis here, we had most of the patients that progressed to treatment, but what's about response in the context of the clinical trial? The median age was 50 years old. ER negative were finally 56%, ER positive 43%. All of the patients received the previous treatment with trastuzumab. And when we consider type of treatment, 42 received T-DM1, 17 dual blockade with pertuzumab and trastuzumab, and 26 other type of treatments. If we go to the data, no response was observed in the PD-L1 negative cohort. All responses have been observed in the PD-L1 positive cohort. 1 response in the phase 1b study, and 6 response in the phase 2 study, with an overall response rate of 15%. So very limited activity. This was a seminal trial. Let's go in the details to understand who were the patients responsive. And here we have in the PD-L1 cohort, the waterfall plot, differentiated in both ER negative and ER positive disease. And looking at disease control in the PD-L1 positive disease was quite similar across ER positive and ER negative disease. The most interesting observation was the progression-free survival and the overall survival by PD-L1 status. You can see here a better overall survival in the PD-L1 positive cohort. Was this prognostic or predictive? We don't know the answer. We have a very limited population, but it was a very interesting observation replicated later in the triple negative population. If we analyze the stromal tumor infiltrating lymphocytes by PD-L1 status and site of biopsy, of course, the baseline stromal TILs were higher in the PD-L1 positive disease and higher in breast, lung, and lymph nodes, respect to liver, skin, or other site of metastatic disease. Importantly, when we consider the baseline TILs and we compare responders versus no responders, we have, of course, higher TILs in patients responders. Here we replicate completely what we observed in triple negative disease. The more you enrich by PD-L1 expression of tumor infiltrating lymphocytes, the more benefit you achieve from an immunocheckpoint inhibitors. We have over there data, of course. We have the data of the CATE-2 trial, finally. The trial was designed for patients with HER2 positive locally advanced breast cancer who received prior therapy with taxane, trastuzumab, but no disease progression, of course, on metastatic therapy or within 6 months of adjuvant therapy. And patients have been randomized to T-DM1 plus atezolizumab versus T-DM1 alone. The primary endpoint was progression-free survival. Secondary endpoint, overall survival, overall response rate. And looking at the data, there was an improvement in progression-free survival in intent to treat population in patients with PD-L1 positive tumors. We have 4.1 months in the T-DM1 placebo arm versus 8.5 months in the T-DM1 atezolizumab arm. No difference in overall survival, even if 1 year overall survival rate was numerically higher with the addition of atezolizumab in PD-L1 IC positive subgroup. This was, of course, an hypothesis generation trial published by Alicia Emmons on the Lancet Oncology. And there is actually another study going that is the CATE-3 study. HER2 positive and PD-L1 positive locally advanced or metastatic breast cancer, patients who received prior trastuzumab pertuzumab, progression of metastatic treatment or within 6 months of adjuvant treatment. And the co-primary endpoint was progression-free survival by investigator assessment using RECIST version 1.1 and overall survival. Patients are randomized to atezolizumab plus T-DM1 versus placebo plus T-DM1. Very interesting study. But I would like to remind also to you that there is a trial in the context of the adjuvant setting, the Astefania study, for patients at high risk with residual disease following neoadjuvant trastuzumab or neoadjuvant trastuzumab and pertuzumab. Patients will be randomized 2-to-1 to T-DM1 plus atezolizumab versus T-DM1 placebo. This is a registration trial including 1,700 patients. So this is a very important study in the adjuvant setting. Another study is the inpatient 030, exploring the role of atezolizumab, in this case, in patients with HER2 positive early breast cancer with primary tumor of more than 2 centimeters. And the co-primary endpoint are pathological complete response in intent to treat population and the PD-L1 positive subgroup. Here we have a combination of chemotherapy plus entire 2 therapy and atezolizumab, both in the neoadjuvant setting and in the adjuvant setting. And this is compared to placebo. An important trial that I would like to remind to you is in the metastatic setting. Why is important? Because here we have the combination of an antibody drug conjugated plus an entire 2 therapy. And it's important to remind that here the combination of immunocheckpoint inhibitors and antibody drug conjugated is explored in this setting. The hypothesis is that using an antibody drug conjugated like trastuzumab deruxtecan, you can really induce much more immunogenic cell death, and you can explore the combination with immunocheckpoint inhibitors like durvalumab, including also one arm with durvalumab and paclitaxel. This is an hypothesis generation trial that it's really important to better explore the role of ADCs in HER2 positive disease plus immunocheckpoint inhibitors. Is there a role for vaccines in HER2 positive disease? I believe now that we had the COVID pandemics and that there was a so important role of vaccines to control the pandemics, I am quite sure there will be a revival of vaccines also in the field of cancer, and specifically in the field of breast cancer. Gene-based vaccine, viral bacterial-based vaccines, peptide or protein-based vaccines, and cell-based vaccines. So we have a really higher and very important scenario of all potential vaccines that we can develop in this setting. And I would like to remind you that a few years ago, we completed a trial in the adjuvant setting using an HER2 peptide. Of course, I would like to remind also the trials of Elizabeth Mittendorf in the CIS, HER2 positive or HER2 low. This was a trial for invasive disease in the adjuvant setting for patients who never received trastuzumab, and the trial used a large peptide, including 919 amino acids, and including the extracellular and the intracellular domain. And the vaccine was, of course, combined with an adjuvant. And there was an intramuscular administration every 2 weeks for 6 administrations. And this was the result, finally. Here we have 3 dose escalations of the vaccine. And at the higher dose of 1,000 micrograms, there was a potent immunoresponse in all patients. And there was an inhibition of in vivo tumor formation. So what's about immuno-oncology in HR-positive breast cancer? Here, of course, the topic is not so explored, I believe. We have also TL in ER-positive breast cancer, even if we have conflicting data on the role of TLs in ER-positive disease. Maybe in ER-positive disease, TLs can be detrimental rather than prognostic of a favorable outcome. But of course, we have also the role of microsatellite instability This is a potential biomarker predictive of benefit of immunocheckpoint inhibitors. We have an agnostic approval for both pembrolizumab and nivolumab in patients with microsatellite instability. And we can have this alteration in ER positive and triple negative disease. I have personally treated 2 patients with ER positive disease and Lynch syndrome with an exceptional response to immunocheckpoint inhibitors. Then we have some proof of concept studies that explored the role of immunotherapy in ER positive disease. The first trial was with avelumab, including both ER positive and triple negative disease, very limited activity. Another trial used tremelimumab, using also this type of immunocheckpoint inhibitor in ER positive disease. And finally, we have the proof of concept of Dr. Goel published on Nature, exploring the combination of abemaciclib plus anti-PD-L1 treatment, demonstrating that the use of CDK4/6 inhibitor may increase immunogenic cell death and can potentially be used to boost with immunocheckpoint inhibitors. There was a trial, finally. The last update has been presented by Hope Rugo during the ASCO meeting in 2020. And this was a study exploring the role of abemaciclib plus pembrolizumab in both non-small cell lung cancer and metastatic breast cancer, HR positive or HER2 negative. If we look at the data in the cohort of patients with ER positive disease, finally, very limited number of patients, 28, there was a confirmed overall response rate of 28%, with a 28 partial response and a clinical benefit rate of 46%. Liver toxicity was the most important toxicity. Another potential combination can be done with HDAC inhibitors. We have some of them that have been approved for ER positive disease, and we can potentially combine HDAC inhibitors like histone acetylase inhibitors, vorinostat plus pembrolizumab. And here we have some data that have been published already. But you know, the strongest rationale to combine immunocheckpoint and chemotherapy is in invasive lobular cancer. We have evidence from preclinical and translational studies that usually in lobular cancer we have upregulation of immune-related genes that are more common, finally, in HR positive disease rather than in triple negative. So there is a specifically immune-related signature associated to invasive lobular cancer. That's why recently Marlene Koch presented during the ESMO Breast meeting the first results of the Gelato trial. The Gelato trial included patients with metastatic invasive lobular cancer with negative or aberrant E-cavering, ER positive disease, maximum 2 lines of palliative chemotherapy. Here there was a planned biopsy at 2 weeks before the use of chemotherapy, and then at 0 weeks and 6 weeks. And the combination treatment included carboplatin given weekly and atezolizumab given every 3 weeks. And here we have the preliminary data of efficacy, in which an overall response rate of 19% have been observed, with a clinical benefit rate of 29%. Looking at the data of the translational endpoint, finally, we have the PD-L1 expression that predicted the major clinical benefit. Finally, the percentage of patients with clinical benefit were much more in the PD-L1 positive group rather than in the PD-L1 negative. PD-L1 was assessed by SP142. Another trial was the GILDA trial, recently published on Clinical Cancer Research. The PI was Prefranco content, and Maria Vittoria Dieci completed the trial. Here is much more interesting because we have patients with luminal B-like tumor, HR positive, HER2 negative, with Ki67 more than 20% or grade 3, premenopausal with stage 2, 3A, so in the neoadjuvant setting. Patients received epirubicin and cyclophosphamide, and then they received nivolumab plus triptorelin and exemestane. So it's really a very interesting study. And looking at the data of PCR overall and by PAM50 subtype was much more concentrated finally in the basal subgroup rather than in the non-basal subtypes. Here we have 4 out of 8 patients with the basal-like phenotype who achieved finally a pathological complete response. And then the TILs, of course, were more present in patients with PCR respect to no PCR. And so if we combine the PAM50 to the TILs expression, of course, we may generate a score that can be predictive of more activity of this combination. There were also specific biomarkers, immunomarkers, predictive of response. Here we have the multiplexed analysis, and the inflammatory response and immunogen signatures were overexpressed in the population of patients with PCR. Also, chemotherapy can modulate the TILs response. Following anthracyclines, there was an increase on TILs, significant increase in CD8, and significant decrease of intratumoral and stromal CD4. So the modulation of chemotherapy was really important. In terms of safety, of course, transaminitis was the most common adverse events. Do we have other trials in ER-positive disease? Yes, we have the 7FL, the trial exploring nivolumab plus chemotherapy as neoadjuvant and adjuvant treatment in ER-positive, HER2-negative breast cancer. And this is an important trial, including 1,200 patients. So any future for immunocheckpoint inhibitors in ER-positive disease? Maybe we have to explore in early lines. Maybe we have to explore in combination of ADCs. And this is quite important because we have many antibody drug conjugated that can be explored in ER-positive disease. Trastuzumab deruxtecan for ER-low, sacituzumab govitecan in ER-positive disease, RC48 in ER2-low breast cancer, and finally also patritumab deruxtecan and TIRE3. So maybe we need a specific trial combining antibody drug conjugated plus immunocheckpoint in ER-positive disease. And there is a trial, the SASHA trial, exploring the role of sacituzumab govitecan not only in triple-negative disease, but also in HR-positive disease. So how we can predict the response in tumors beyond the triple-negative breast cancer? So you would agree with me that in ER-positive disease, it's much more clear that we have cold tumor, excluded tumors, and immunological hot tumors. But it's much more important to remind that in the future, we need a more composite score to predict the response to immunocheckpoint inhibitors. We have PD-L1, we have surrogates of immune response, we have tumor mutational burden, microsatellite instability, and the major question will be whether the early immunological response correlates with the clinical response, whether there are baseline parameters that can predict immunological response, whether distinct subtype of immunological non-responsive tumors can be identified. And that's why the question is more complex than cold, hot, and hot tumor. And recently, we have here a tumor that is immunodesert, excluded, and inflamed. And recently, this very interesting paper has been published on Nature Medicine from the NKI group. This is a study exploring ex vivo tumor fragment platform to dissect response to immunocheckpoint inhibitors. And in the context of this tumor fragment platform, investigators identified immunodesert tumors, but they also identified immunoinfiltrated tumors that are, let's say, infiltrated but not responsive, and immune-infiltrated tumors that are responsive. And in the responsive tumors, usually we have an upregulation of genes that are involved in the immune response, exactly like the data presented by Dr. Pardo and by Dr. Hendricks, identifying specific immunosignatures that may predict at baseline response to immunocheckpoint inhibitors. We don't have to forget also that another important role is related to neoantigens. And in other tumors, like in non-small cell lung cancer, we have mutation-associated neoantigens that can drive anti-tumor immune response. So that's why it's important to better classify neoantigens in ER positive and HER2 positive disease, because this can be the rationale also to build a new platform of vaccines beyond immunocheckpoint inhibitors. So in conclusion, we need a better definition of the immunogram in ER positive and HER2 positive breast cancer. The tumor genome can be still a driver of cancer immunity. The immune response to cancer is dependent on T cells that are specific for cancer-associated antigens, and we need to understand much more what is going on in HR positive and HER2 positive disease. And change in gene expression in tumors may bring, of course, to epigenetic modifications and probably contribute directly to determining the immunomicroenvironment and immunogenicity of a tumor. So all the trials that have been presented, like the Gelato or the JADA trial, should explore this. And then we have very limited data on microbiome that should be much more explorable in the context of breast cancer. So thank you very much indeed to Dr. Koch, Dr. Dieci, and Dr. Kukos for providing the information of their trials. And I am here to answer to all your questions. Bye.